It's 12 noon, let's get started. Hello, this is Vijay Hibatuman, the interim chair of the Deming Department of Medicine. Thank you all for joining today's Grand Rounds. Our speaker today is a distinguished member of our faculty and a great friend, Dr. Keith Ferdinand. Although scheduled before the current heartbreaking event sweeping the nation broke out, Dr. Ferdinand's appearance today is particularly poignant. These unconscionable series of events, the wanton display of unrelenting cruelty, hurt all of us and profoundly offend our sense of decency and justice. Today, Dr. Ferdinand, a nationally prominent African-American physician and academic leader, will discuss yet another form of injustice faced by the African-American communities, namely health disparities, this time in the context of COVID pandemic. Before turning the podium to Dr. Ferdinand, a few words about his qualifications and accomplishments are in order. Dr. Ferdinand is the Gerald S. Berenson Professor of Medicine at the Deming Department of Medicine, Tulane University School of Medicine, and Tulane Heart and Vascular Institute in New Orleans, Louisiana. He was previously Professor of Clinical Pharmacology at Xavier University in New Orleans and Clinical Professor of Medicine at Emory University, Atlanta, Georgia. Dr. Ferdinand received his medical degree from the Howard University College of Medicine in Washington, D.C. He is board certified in internal medicine and cardiovascular disease and the subspecialty of nuclear cardiology. He's also a specialist in clinical hypertension, certified by the American Society of Hypertension. Dr. Ferdinand is the past chair of the National Forum for Heart Disease and Stroke Prevention, the chief science officer and past chair of the Association of Black Cardiologists, board member of the American Society of Hypertension, Southwest Lipid Association, and the International Society of Hypertension in Blacks. He's presently on the board of American Society of Preventive Cardiology. As an investigator, Dr. Ferdinand has conducted numerous trials on cardiovascular disease, hypertension, heart failure, lipids, and cardiometabolic risk, especially in racial and ethnic minorities. He has published over 200 papers in top peer-reviewed journals, including the New England Journal of Medicine and the Journal of American College of Cardiology, among others. He has lectured nationally and internationally on topics including cardiovascular disease, heart failure, hypertension, diabetes, dyslipidemia, and racial and ethnic disparities. In 2004, Dr. Ferdinand received the Lewis B. Russell Jr. Memorial Award of the American Heart Association and the Walter M. Booker Community Service Award of the Association of Black Cardiologists. The Congressional Black Caucus Health Trust has recognized him with an award for journalism. He's also the recipient of the Charles Drew Award for Medical Excellence from the National Minority Quality Foundation. In 2015, Dr. Ferdinand was inducted into the Association of University Cardiologists. His other awards include the Wenger Award for Medical Leadership by Women Heart, the ABC Spirit of the Heart Distinguished Leadership Award, the 2019 Xavier University Champion Award for Health Equity, and AHA 2019 James B. Herrick Award for Outstanding Achievement in Clinical Cardiology. It's a pleasure to have Dr. Ferdinand. I expect at the end of his presentation, there may be some time for questions. So please type your question in the question box at the bottom of your screen. And Keith, thank you for joining us today.
Thank you, it's my pleasure. I'm going to discuss COVID-19 and the increased mortality in African Americans and other minorities, but I'm also going to build into some cardiovascular risk, mortality, and disparities in terms of risk factors, and some social justice issues. And I'm sharing my screen. Here are my objectives. I'm going to first talk about some of the disparities related to cardiovascular disease and mortality. I'll use publicly available data. I'm going to do this very quickly. Most of you are aware that these disparities are real. Some of you may not recognize how long-standing and how profound these disparities are. Then I'm going to talk about the impact of race, ethnicity, and social justice, including post-natural disasters. Here in New Orleans, we unfortunately had the disaster of Katrina and its impact on the population. And then we'll go directly to COVID-19 pandemic and some of the underlying causes and perhaps solutions related to the African-American mortality. These particular statements were made in 2002 by the Institute of Medicine. And unequal treatment. Health, life expectancy, and care has improved dramatically for all Americans over the last century. However, these benefits have not occurred equitably. At that time in 2002, and unfortunately today, there's a real mortality gap between Blacks and whites. Cardiovascular disease is perhaps the strongest driver of this mortality gap. African Americans have higher risk of hypertension, diabetes, obesity, especially in Black females, premature myocardial infarction, stroke, chronic kidney disease, end-stage renal disease, and overall cardiovascular mortality. America has a long way to go. If you have patients in the Medicare age population and older, many of them grew up in a segregated system. The Civil Rights Act was passed in 1964, followed by the Voting Rights Act. You see peering over the shoulder of Lyndon Johnson. This means that some of the legacy of discrimination and segregation are etched indelibly in the minds of your older patients and clients. Many of you practice here in New Orleans at the University Medical Center. The actual formal name for the hospital itself is the Reverend Avery Alexander Academic Research Hospital. And most of you don't really know who Avery Alexander was. He was a civil rights leader, a minister, and here, unfortunately, you see him being dragged by his ankles down the steps of City Hall. What was his crime in October of 1963? He tried to eat in the cafeteria at the New Orleans City Hall. Let's first talk about some of the disparities in cardiovascular disease, socioeconomic status, and overall mortalities. Most clinicians recognize that African Americans are a higher risk population. Here are data comparing non-Hispanic whites to non-Hispanic Blacks. Now you should note that the x-axis is related to time. So this is data which has been persistent over the last several decades. There has been a downward decrease in the top bar, that's all cardiovascular disease. But the y-axis conclusively shows that all cardiovascular disease, although decreasing, appears to be plateauing most recently, with a real disparity in mortality, that's death rates, when comparing Blacks to whites. And if you look overall, nothing captures these health inequities as clearly as the persistent expectancy between whites and Blacks in longevity itself. Again, many of you may not be aware that this has been persistent for decades. The bottom line are non-Hispanic Black males, clearly among the major racial, ethnic, sex groups in the United States, have the shortest life expectancy, clearly less than that of white males. While the gap has narrowed minorly over the last several years, it is still persistent. The dark blue are non-Hispanic Black females, again, a white-Black mortality gap between non-Hispanic Black females and non-Hispanic white females, which has been persistent over the last several decades. Here in Louisiana, unfortunately, when you look at the determinants of health and overall health, we rank at the bottom along with Mississippi in terms of our ability to protect our citizens from disability and death. Geomapping, looking at geography, does suggest that there is something that goes beyond genetics and simple qualifications of being either white or Black that says that there are impacts of social determinants in health. Here is a heat map. These data are from the CDC. The dark areas are where you have the highest prevalence of hypertension, and you can see Louisiana at the bottom, along with other states in the Southeast, good for football, bad for hypertension. And when you look at heart disease death rates, it mirrors what we just saw in hypertension, with some of the highest rates in Louisiana, Mississippi, Alabama, Arkansas, parts of Oklahoma into Missouri, Tennessee, Kentucky. And the percentage of persons living in poverty. Again, suggesting, and this is based on geomapping, that the social determinants are not isolated, but have an impact on health risk factors and overall mortality. We live in an area that's called the Mississippi River Delta. This is a CDC term for the area that's in the gray at the lower end of the Mississippi. We have an increase in mortality rates in this geographic area for all causes. I'm focusing on cardiovascular disease and overall mortality, but the same could be done for cancer, infant mortality, maternal-related mortality. And the rates of death are about 20% higher than that seen in other areas of the United States. There's something that must be said about history. And clearly, when you look at the map of the slave trade prior to the Civil War, where New Orleans was one of the biggest areas for the slave market, you cannot overlook the fact that it mirrors much to what we've just looked at in terms of cardiovascular mortality, risk factors, and poverty. We as physicians are not divorced from this reality. This is a formal paper written by Samuel Cartwright, a physician at that time at the University of Louisiana, now known as Tulane University. And Dr. Cartwright maintained that enslaved people had a disease of the mind called drapetomania, which caused them to run away from their enslavers. And what was his cure for drapetomania? The slaves who would run away, he prescribed whipping the devil out of them as a preventive measure. So when we look at control of risk factors, here is hypertension. There clearly is lower rates of control across racial ethnic minorities, including Blacks, but perhaps one of the greatest markers for poor control of hypertension is having uninsured status. Persons who do not have an identifiable source of care will allow risk factors to remain uncontrolled for decades and then use the emergency room as their primary source of care. The same is true of diabetes. Here the legend has changed. Non-Hispanic Black is in the red, both for females and males, higher prevalence of diabetes. And a racial difference in end-stage renal disease, with African Americans being approximately 13.6% of the population, but representing over 30% of persons who have end-stage renal disease. This is important because healthcare dollars are wasted by what is often a preventable condition related to poorly controlled hypertension and poorly controlled diabetes. Heart failure, which is the most common cause of admission for persons who are over 65 in the Medicare population. Again, the legend showing Black men and Black women having clear higher rates of heart failure starting at the younger ages and persisting into the 65 and 84 years of age section. Now, what causes these conditions? Well, clearly there may be some biology or genetic factors in play. We know of the APOL1 gene. If it's recessive, it increases the risk for chronic kidney disease. But I think overall, it's environment, diet, lifestyle, and socioeconomic status, which has a profound effect on the outcomes that we've just described. And indeed, the whole concept of race ethnicity is a social construct with little biologic or genetic basis. We cannot afford to remove ourselves from the reality that even in healthcare, there's implicit bias and stereotyping, which are real phenomena and affect health and disease itself, and may be part of the root causes for some of these disparities. This particular statement is not mine. It comes from the American Heart Association in their description of the impact of the social determinants of health on outcomes. Overweight and obesity status, especially for Black females, is clearly part of the puzzle. And we know that the Southern diet, while tasty, may have a profound impact on cardiovascular risk. This is the REGARD study, which is a large cohort study of whites and blacks in the southeastern part of the United States. And they suggested that the high Southern diet was one of the largest mediators of the difference between blacks and whites in hypertension, with a high intake of fried foods, organ meats, processed meats, eggs and egg dishes, high-fat dairy products, sugar-sweetened beverages, and bread. Interesting, the REGARD study had shown prior to the COVID-19 pandemic that these type of dietary patterns not only increase the risk of cardiovascular disease, may also increase the risk of sepsis. 8 Americas was a study that showed if you divided the American population into race-county combinations using income, education, and where a person lives, that there really is not just one America. I pointed out the first author of this paper. It's a gentleman whom I knew well before the pandemic, Chris Murray. And Chris Murray actually now is the lead in the Institute for Health Metrics and Evaluation, which is the modeling that we have related to COVID-19. Prior to that time, he described that in the United States, depending on where you live, your geography, your race, ethnicity, poor urban blacks had the shortest life expectancy, with a 14-year difference between those at the highest and the lowest group. Here are data that are seen post the 8 America study, looking at the relationship between income and life expectancy. And I use hard mortality endpoints because it suggests to you that these racial disparities is not social science. This is not just looking at how people feel about each other, but an actual issue related to life and death itself. Here, in terms of life expectancy, the persons who are at the bottom 1% versus those at the top 1%, there's a real difference of a life expectancy gap of about 10 years in women and about 15 years in men. We often hear politicians and pundits say that America has a fractured healthcare system because despite spending more per capita for healthcare, we have one of the shortest life expectancies among Western European and Japanese populations. I actually think that's false. Those of us who live in America, who live in social, stable environments, who have adequate income and education and access to healthcare with an identifiable source of primary care and appropriate referral to a specialist, actually live as well in terms of life expectancy as anyone from Japan and Western Europe. And indeed, it is those persons who are at the bottom who have shorter life expectancies that makes the median life expectancy in the United States only 16th among developed societies. Here are current data that were released within the last week that again shows the association of lower socioeconomic status and premature heart disease. Using the gold area, they suggested anywhere from 20 to 30% of premature coronary disease is attributable to low socioeconomic risk factors. And using modeling, they suggested going forward, while we as clinicians must address traditional risk factors, that unless we address these socioeconomic disparities, it's unlikely that we'll be able to change these disparities in outcomes. I'm going to move on now to natural disasters before I go to COVID-19. This is a paper that was written by myself along with Harriet Van Spald and Clyde Yancey, observing that the disparate outcomes that we see in COVID-19 harken back to the aftermath of Katrina. And indeed, in Katrina, the levee, which was located at the Industrial Canal, burst, flooding the lower Ninth Ward, killing hundreds of our citizens in that area, and about 1,500 throughout New Orleans and the metropolitan area. You see there the breach in the levee, the large barge, which dwarfs the houses which have been flooded by the waters post-Katrina. This is actually a picture of a street in the lower Ninth Ward. I lived on Flood Street. I'm a child of the lower Ninth Ward. And this particular picture was taken post-Katrina in 2005. Unfortunately, as a child, I also experienced flooding in the same area in 1965. And in fact, I lost my paternal grandfather, who we could not save from drowning, and spent 2 days on the roof of our home in 20 feet of water with death and dying persons all around. Post-Katrina, therefore, we saw that those persons who had limited means to escape the ravages of the storm and to evacuate during the mandatory evacuation of August 28th were left alone to fester and often die post-Katrina. This has been studied. Here's a report looking at the vulnerable populations, and what they suggested was that there were anecdotal evidence that those who had limited means had a greater impact on their survival post-Katrina related to hypertension, diabetes, end-stage renal disease, chronic metabolic illnesses that was highly prevalent in the lower socioeconomic groups. And indeed, this has also been studied by cardiologists here at Tulane, who have suggested that post-natural disasters, 6 years after Katrina, the percentage of persons who were admitted with acute myocardial infarction to the Tulane Medical Center increased remarkably when compared to 2 years before Katrina. So now let's go to COVID-19 and its devastating impact on African Americans. These are data looking at the percentage of the population in a state or area in the blue versus the share of deaths related to COVID-19. These data were as April of 2020. They're changing. I know that the percentage in Louisiana, for instance, has decreased somewhat when compared white versus the general percentage of the population. But if you're looking at these data, it suggests in a wide geographic, diverse area that African Americans have a higher rate of mortality related to COVID-19. You can get updated information from the Louisiana Department of Health. This is another way of looking at the data, which I often don't hear people discuss. And that is, within a population, those higher mortality rates translates to more persons being affected within that community. So the rate of COVID-19 deaths per 100,000 is exponentially higher in the Black community. I personally have lost a childhood friend and a member of my extended family from COVID-19. And many members of the Black community are very sensitive that this pandemic has ravaged our community in a non-equitable fashion. We often hear about the underlying conditions, and I've spoken to you about cardiac risk and cardiac disease, higher rates of obesity, diabetes, cardiovascular disease, and clearly these are risk factors for increased hospitalization and mortality with COVID-19. However, you cannot explain the high disproportionate degree of death and mortality with COVID-19 simply due to the higher rate of risk factors. This is a very nice lay population reported data from the National Geographic, and they looked at the history of the coronavirus in the United States. And they suggested that it was a toxic storm of death and illness that was devastating the Black community. I was called to be interviewed for this particular journal's magazine, and it suggested to me that I needed to tell them that there was a mixture of many difficulties that faced African Americans, which may compound and extend the burden of coronavirus infection, that it's not simply a disparate degree of risk factors. What are some of those factors? Working in service industries, or the so-called essential jobs, where persons were exposed more to infection, where they could not social distance or work from home. Using public transportation to go to work. Lack of access to early testing, especially early on in the pandemic, where people only presented to the emergency department of various hospitals already in the throes of COVID-19 and not aware that they had the condition. And of course, based on some of the historical elements that I've demonstrated to you, there's a real historical distrust of the healthcare system because of previous bias. This is one of the pictures from the National Geographic article showing Chicagoans, essential workers, taking public transport to get to their work and meet their basic needs. There are also racial disparities in incarceration, which appears to be a social justice issue, but is also related to COVID-19, since these have been areas which have been hotspots for infections and increased mortality. The percentage of non-Hispanic Blacks, when compared to percentage of their population, along with those for Hispanics, are clearly disproportionate, indicating another risk factor for mortality with COVID-19. And what about New Orleans itself? These are data from 2018. Non-Hispanic Black is in the dark blue. And looking at households earning less than the living wage, employment rates, and educational attainment, there's more poverty, less employment, and less degrees of education. This actually can impact the ability of a person to understand how best to navigate our very complex healthcare delivery system, to get early testing and early care once they have a COVID-19 infection, and to seek appropriate care when they're in the throes of the disease process itself. What about New Orleans? I often bristle when people throughout the nation suggest that we were partying and having a good time when there was a pandemic going on. That may be true, but Mardi Gras itself was a level 2 Homeland Security event. And this is directly out of their website. I have not changed a word. They said that they were there for New Orleans to pass the good time and make sure we could do it in a safe manner. Mardi Gras was February 25th. This is the Endymion Parade on February 22nd. And our first case was not actually reported to March 9th. But clearly coronavirus was already present in the Crescent City at that time. One of the best papers, again, was just released last week that looked at hospitalization and mortality among Black and white patients with coronavirus. The first author was previously here at Tulane Medical Center, Ebony Price Haywood. They did a retrospective study of patients who were diagnosed and admitted to the Ochsner Health System. 70% of the patients who were positive for COVID-19 were Black. This is so unusual because in the conventional Ochsner population, only 31% are Black non-Hispanic. Furthermore, when you look at the 3,481 COVID-19 positive patients done in the Ochsner system, many were tested in the emergency department. When compared to whites, 65.3% versus approximately 38%, suggesting that these patients did not have usual sources of care, did not have appropriate early diagnosis, but were only found to have COVID-19 when they were in the throes of their condition. High Medicaid insurance, living in a low income area, all also were descriptive of Blacks versus whites with COVID-19. I do list those comorbid conditions and risk factors which we described earlier, but they were not as disproportionate as the rates of diagnosis and hospitalization with COVID-19, clearly indicating that conventional risk factors themselves do not completely explain the picture. Out of those who were positive, 39.7% were hospitalized. And looking at those patients who were tested positive and then hospitalized, almost 80% were Black. Those admitted to the ICU, 80.2%. Those placed on mechanical ventilation, 81.6%. And those dying in a hospital system, which prior to the pandemic only had approximately 31% non-Hispanic Black clients, 70% were Black. Looking closer, you'll see that we often will utilize male sex as a marker for higher hospitalization and death with COVID-19. But because of the predominance of Black patients, there appears to actually be more females. The age trends a little younger, perhaps driven by higher risk factors and obesity. And residents in low-income areas clearly is a driver of showing to the hospital later in the process and needing hospitalization with COVID-19 in the Ochsner system. Fortunately, once the person did reach the intensive care, the death rates, although it's unfortunate for both whites and Blacks, was no different compared to the white and Black population. So what can we do? How do we address this higher COVID-19 African-American and minority mortality? I stood up for nights trying to figure how best to describe this situation, and what I suggested, along with my co-author, Samar Nasser from George Washington University, that this was a sentinel event, the type of occurrence that happens when the Joint National Committee is evaluating hospital care, such as unintended retention of foreign objects or falls in a hospital setting, that suggests that there may be poor quality in the hospital system. Similarly, the disparate African-American COVID-19 mortality rates reflect long-standing and unacceptable US racial and ethnic and socioeconomic cardiovascular inequality. And this high mortality rate unmasks systems failures and an unacceptable level of care that we need to have caught and mitigated. Let's talk about some potential practical positive actions that may help going forward, specifically related to COVID-19. I suggest target culturally sensitive, literacy appropriate education regarding social distancing, the use of masks and hand washing. Personal protection for the so-called essential workers, the custodial workers and the clerical staff, the mass transit operations, many of whom were affected disproportionately by COVID-19, including sanitation workers, and financial protection and permanent insurance for non-covered workers. Early in the pandemic, there were drive-through testing, but remember, similar to Katrina, where approximately 40% of persons in New Orleans did not own a personal automobile and could not escape the ravages of Katrina, many people don't own a car. So testing in an environment where a person can walk into the facility may actually get earlier diagnoses and help for identification, contact tracing, and care. Testing essential workers and their family members for diagnosis, and in the future, perhaps immunity testing. Encouraging the control of cardiovascular risk factors. These risk factors don't cause COVID-19, but may amplify the cytokine storm and the inflammatory reaction to the infection. Should we encourage home blood pressure monitoring, control of blood pressure, home scales, control of overall cardiovascular risk factors, and diabetes care. And we should educate our patients that they should not be afraid to seek emergency care for cardiovascular concerns outside of COVID-19. Remember, the second wave post-Katrina was an increase in acute myocardial infarction. We may be able to help our patients with low cost or virtual physical activities online. And some patients may benefit from the use of thermometers, and if they have been diagnosed, home pulse oximeters, such that they can monitor their status and seek care when appropriate. And we should encourage local and state task force to correct racial and ethnic COVID-19 disparities. Fortunately, some of my ideas that I wrote in this particular editorial in the Journal of the American College of Cardiology have come to fruition. And here in Louisiana, the governor has set up a Louisiana COVID-19 Health Equity Task Force. It's led co-chair Tom Levis, the dean of the School of Public Health here at Tulane, and I'm honored to be part of that task force. The goals are to provide reliable data and information on COVID-19 safety and prevention, assist the medical community with best practices and protocols on how to outreach and treat disadvantaged populations, and to ensure testing availability and ease of access for all communities. I'm not yet convinced that these particular approaches are going to be completely reverse the increase in mortality that we see in disadvantaged populations, but at least there's a first step to try to identify and seek how to curtail those outcomes. How do we reach health equity? It's not good enough to simply say we're all Americans and we're all the same. Clearly there are disparities. We need targeted programs designed to give the little person a step up so that we all can have the same quality of life and longevity. I started this particular presentation with Martin Luther King, and most of you know him from access to voting rights, public accommodations. But Martin Luther King also said in 1966, of all the forms of inequality, injustice in healthcare is the most inhumane. So in conclusion, when you look at these inequities, it goes well beyond social science. These health disparities by race, ethnicity, and socioeconomic status exist. They're sizable. They impact not just quality of life, but mortality itself. And they're most likely multifactorial. I don't think there's one gene or one set of genes that can explain the high rates of death and disability that we see among the disadvantaged populations in the United States. The COVID-19 inequalities and increased mortality only serve to reveal and exacerbate already long-standing inequities. Thank you very much. Dr. Bonneman, perhaps we may have time for a few questions.
Thank you, Keith. That was a very sobering presentation. We really appreciate that. I think we have time for questions and answers. If there are any questions from the participants, please type your question. I think there is also a raise hand function. You can do that as well. Dr. Ferdinand will kindly try to answer them. We'll take a few minutes. I don't see any questions at this time.
Well, while we're waiting for questions, I would say that there's some unpublished data coming out of Tulane that the obesity, cardiometabolic conditions may actually be part of the puzzle for driving mortality once the person is hospitalized, leading to higher rates of ICU care. And you know, once you have ICU care and mechanical ventilation, the mortality rates are quite higher. But what I'm suggesting is that those underlying factors have to be commingled with the social determinants and some of the structural factors, not having identifiable source of care. If you remember from the Oshner data that we just covered, almost 60% of patients being diagnosed in the emergency department, meaning that they were probably home, frankly symptomatic for days before they sought care.
There are a number of questions. I'll read them in sequence, one at a time. Dr. Coles is asking, what are some of the other key structural issues we need to change in healthcare to reduce disparities?
I think in general, universal healthcare is must. We often hear the slogan that healthcare is a right. But I think even if you look at it, whether or not you're in the political spectrum, independent, Democrat, Republican, you can clearly suggest that if a person does not have insurance and identifiable source of primary care, appropriate referrals to specialty care, they're going to get care, but the care is going to be in the emergency department. When are you sick? You go to the emergency room. And at that time, the person comes in with swelling, shortness of breath, heart failure, chronic kidney disease. They may present with a first-time stroke. Diseases, if they had had preventive care, would not have even manifested themselves at a young age. The other problem with patients who use the emergency room as the primary source of care, they will have multiple admissions. And if they come back, for instance, with heart failure within 30 days, the hospital pays a penalty for that care. So it makes real sense to me that we would be better off if we gave all citizens, regardless of their employment status, access to insurance and made sure that we had identifiable sources of primary care.
Dr. Fortino is asking, do any of the studies reflecting disparities incorporate stress markers such as cortisol and things like that?
Yes, there's a clear relationship between stress and cardiovascular disease and stress and outcomes. The reason we usually don't list it in our major cardiovascular risk factors is not because it's not a risk factor, but because it's often difficult to demonstrate in large populations. We usually identify our risk factors based on large community cohorts, the Jackson Heart Study, the Framingham Study, and we use the data that's available in those particular subsets of studies to make assessment of atherosclerotic cardiovascular risk. But there have been studies looking at cortisol levels, looking at meditation, yoga, relaxation response, that blood pressure, heart rate and blood pressure variability are all related to stress and stress-related hormones. But it's not a part of our ASCVD risk calculator because those data are just not there in the big pool cohorts that we use to assess risk.
Michelle Blith is asking, what do you think is the best way that physicians can help make and support these changes to help change this narrative?
I think we as healers first should treat everyone the same. We should look at our own biases and make sure that when we see a patient, we don't just treat the disease that's present, but assist that patient with understanding his or her condition and have continuity of care and coordination of care. It's often difficult for physicians, nurse practitioners, and other providers to do that because we have very busy schedules. But there's no reason to think within our 12 to 15-minute visit in which we mumble things and send out an electronic prescription, that's really going to change the outcome of that person going forward. We need to have team-based care. We need to have appropriate follow-up and take the extra time to help the patient understand why he or she needs to have a certain diagnostic intervention, therapeutic intervention, or medication. If we don't, the patients may smile and look at you in a very pleasant manner, but totally ignore what's been suggested. If you go back to the fact that the civil rights movement in the United States was in the 60s, and you just do a quick calculation, most of your patients who are 65 years and older grew up in a situation in which discrimination, poor treatment, mistreatment is indelibly sketched into their memories. And they may not articulate to you, but I think the mistrust of conventional healthcare leads to some of the issues that we see in terms of non-adherence, recurrent use of the emergency room as the primary source, recurrent rehospitalizations, and even patients who have life-threatening conditions such as diabetes and chronic kidney disease, severe hypertension, not really understanding or believing that they should adhere to what's been suggested in terms of diagnostic interventions or care.
Okay, the next question is from Holly Golden. I have heard that there was an understanding in the African-American community that they were immune to COVID-19. Please comment, thank you.
That's actually true. I have firsthand information and have actually been told by members of the community early on in the pandemic that Black people don't get COVID. I don't know where some of this misinformation comes from, but it did lead to the idea that you don't have to social distance, you don't have to, quote, worry about COVID-19. One of my childhood friends who died from COVID, I actually saw on Mardi Gras. I was out there also. And I will tell you, to a large extent, even after the pandemic was clearly manifested, many people in the African-American community did not really embrace the idea that this is something that we should, quote, be worried about. Even after now, over 100,000 Americans have died, it is easier for many people to understand, stay home, don't go out, than you can now come out, but keep 6 feet, hand wash, wear a mask. The algorithm becomes so complex that most people will come out and just return to their previous patterns of behavior. And I will be not surprised if we will see spikes and recurrent episodes of increased disability and death for COVID-19. And we're going to see some of the same disparities as patients seek care, but later on in the disease process.
The question from Dr. William Braddock. Dr. Ferdinand, can you please elaborate on the Homeland Security presence in New Orleans and what you were implying there was the effect on the COVID-19 rate and infections in New Orleans? Did you mean that perhaps outside government employees who were asymptomatic who came to New Orleans contributed, or did you mean something else?
I mean a lot by that. The first thing I mean, the reason I show that is because I still have conference calls with my colleagues from around the nation. And some of them will make sly comments about New Orleans and Mardi Gras. We weren't aware of the impact of COVID-19 at the time. And it wasn't that the federal government did not make us aware. It's not that the federal government, quote, didn't tell us about it. It was the opposite. The federal government enabled the carnival celebrations. They were embedded in the parades. They had a Homeland Security Level 2 event, which New Orleans, in conjunction with the federal government, held, such that when the persons came and visited, 300, 400,000 visitors over several days, the New Orleans population was disproportionately affected by COVID-19. But I just wanted to make it clear, similar to how some people will blame African Americans for their high rates of death and disability, that sometimes there are forces, structural forces in society that impact a community that the community doesn't control.
Is a question from Kristen Noel from J. Cole's lab. Although you answered a good deal of this, but I'm going to read it to you. What are some ways to address these socioeconomic problems?
Well, it's hard for us clinicians to change the society, but we clearly, as citizens, should support universal health care. We clearly, as citizens, should be aware of the impact of having disenfranchised populations. And those programs which are able to assist programs, whether it be the living wage, whether it be prison reform, they will pay off for those of us who are wage earners, because it will be less of a tax burden on the back end. When you look at the statistics that I showed you in terms of the prison population, I tied into COVID-19 because we know that those are petri dishes for coronavirus infections. But it also is tied into lives lost. I have family members, young people who were just as bright, just as happy, just as talented as I was, who then got caught into the ravages of the drug trade, were arrested, incarcerated, and now can't work for a Fortune 500 company because of their prison record, and spend their time in menial jobs in the hotel, motel, restaurant industry, where we joke that it's minimum wage and all you can steal. Those are the type of jobs where you really don't have insurance, although you're employed. When the Super Bowl leaves and the Final Four leaves and the Sugar Bowl is over, the boss often says, Joe, we don't need you next week. So they have a job, but they don't have the living wage, they don't have the support that allows them to have a sustained, stable income for their families. And it sounds like a social issue, but what I'm suggesting to you is that it becomes then a real survival issue, and it becomes wages loss, it becomes income loss, but it becomes a lack of a contribution to a positive quality of life for all of us, including those of us who have stable incomes and have insurance and are able to navigate this very tortuous system. For the people at the bottom, it's rough, and it's not just how you feel or how you think about them. It's a real white, black death gap. And that's why I showed those data. They're readily available. Go to the CDC and you'll see them. And it's almost shocking and surprising that for decades we've allowed these type of mortality gaps to persist.
Okay, a question from Medea Gabriel with Tulane Department of Pediatric ID. Her question is, with the current social atmosphere, including widespread protesting, do you think there will be a second surge of COVID-19? With that expectation, do you think the current changes in access to testing will identify cases quicker and lead to earlier treatment?
Well, first of all, I tried to stay very much with publicly available data. I tried to stay with hard endpoints as I described this. So now you're asking for personal opinion, but I'm willing to give that if I'm allowed. I do think the March for Social Justice is purposeful and has a benefit, but I'm also concerned that all of those people who expose themselves to others may actually have a spike in COVID-19 infections going forward. Widespread testing is not available in all communities. New Orleans actually does a pretty good job, and we now have mobile testing going out to certain areas, and we have walk-in testing, which we did not have early in the pandemic. So I will be surprised if we don't see a spike in coronavirus positivity in the next 2 to 3 weeks. When I talk to my family member and community members, and this is not Dr. Ferdinand, when I'm talking to them as Keith, I'll say, it's like red beans, man. You got to soak the beans have to simmer. And yeah, you feel fine now, but it's going to take some time for the coronavirus to cook. So you need to protect yourself now because you may be sick in 2 to 3 weeks. So that's a long way to give you the short answer. Yes, I think it's going to have a deleterious effect in the future.
A question from Margo Anderson. An impact of racism itself has been shown in maternal and neonatal outcomes. Is this apparent in cardiovascular risk as well?
Absolutely. You didn't hear me use the word racism because it becomes a catch term and people will recall and not listen to the data or the points that you're trying to make. So I usually don't even use that word. But if you're talking about structural inequalities, if you're talking about systems related to healthcare, prison, incarceration, infant mortality, maternal mortality, clearly those structural things impact life itself. And there's so much built into our system that we have to make a positive effort to overcome those structural inequalities, or it will not make a big difference. The picture that I showed with the little cartoon person in the box helping them to reach health equity is not mine. That comes from CDC. It's actually on the website. And what they're suggesting is that you have to have targeted approaches to overcome these structural inequalities, and simply having goodwill or how you feel about a person, whether you like a person or whether you call them a certain name or not, is really not what I'm talking about. I'm talking about the actual structural realities related to income, insurance, identifiable sources of primary care, education, housing, zip code analysis of food deserts, how people are treated or mistreated in the society. Those are bigger concerns to me personally, and I think in terms of these mortality gaps are much bigger concerns than whether or not a person calls you by a certain name or the cartoon or the tweet rub you the wrong way.
Anna Sanford is asking, what programs do you see in New Orleans currently that work to address these systemic issues? Or if you don't see many currently, what do you think this would look like in New Orleans?
Well, we need to do continued work with housing and education. I'm not really sure that completely disbanding all of the public schools was the right way to go. I volunteer with a group of men called Silverbacks, named after the silverback gorillas in the highlands of Africa. And we go into the schools and mentor young Black men so that they understand that their lot in life is not similar to be another cog in the wheel of injustice, to not simply be a hotel service worker for the hotel restaurant industry here in New Orleans, that they can ascribe to do better, to do other things if they so desire. So we mentor those young boys so that they can see better. You know, coming from the community and coming from the neighborhood, people would often wonder, why do Black youth shoot each other? Why do they kill each other? And one of the reasons was, when you talk to these guys, they will tell you, I ain't got nothing to live for. They're actually almost working from a position of chronic depression where the future is nebulous at best. So what's my fear? Is my fear of losing out on something? The answer is no. And even one of my friends who had been previously incarcerated will say, whenever they would do drug sweeps, if he heard on the news there was a drug sweep going on, he'd go sit at the front door because he knew they were coming to get them. So people then start to believe that their lot in life is intrinsic and inexorable. So that leads to less positivity and less forward movement. So we have to overcome that. I think that's something that we have to do ourselves within the community, but those of us at Goodwill need to support initiatives. We need to be able to understand that if we don't have those structural things that I talked about, education, insurance, access to healthcare, publicly sponsored programs, then we're going to still keep repeating these patterns of inequality, these patterns of death and disability. And if you can recall my lecture, and again, I would charge all of you to seek your own data, go to the CDC website, you'll see that those gaps, those life expectancy gaps, have been persistent for decades. I think most of us just not aware of it because we don't live that life. We live fairly comfortable in our own bubbles. We hear about it, we kind of know about it, but we don't really recognize how death, disability, and disparities are so much baked into the American pie.
Thank you. Hewitt Abadi is asking, based on your experience, can you name one health policy that was implemented at a medical center and made a positive impact on racial minority patient health outcomes?
In a health center particularly, I will tell you the Affordable Care Act, we have data now that those counties that did not extend Medicaid and offer the Affordable Care Act have worse cardiovascular outcomes than those that do. So that's why I drive home the universal health system. Within the hospital setting, I trained at Big Charity, which is right across the street from Tulane Medical Center next to the medical school. And we used to have health navigators who were laypersons who would go into the wards and assist patients with making sure they could get their medicines, make sure they had a follow-up visit, to enroll them in Medicare at that time and Medicaid if they met those requirements. And I think those type of health navigators within a system actually are beneficial because, again, I drive home the point that many of these persons are overutilizers of the emergency department. So if you treat the heart failure, if you treat the renal failure, if you control the malignant hypertension, and you don't ensure that they have access to medications, identifiable source of primary care, understanding of their medications and how to get and afford their medications, they're going to get care. They're going to show back in the emergency room. And again, it's going to be a cost, which is often a cost that's lost to the medical facility. Those facilities then are taking care of patients who have higher comorbidities and they have poorer outcomes, and they're deemed to be somehow substandard institutions. Thank you very much for this opportunity, Dr. Bonneman. And I know it was somewhat far afield from COVID-19, but people asked questions and I tried to address them.
We thank you. We're grateful for this presentation. I apologize to participants whose questions we don't have time to answer, but I would like to point out that they can write to you directly to your email address. And you told me that you would be happy to try to answer them. Thank you very much for all joining the grand rounds, and have a safe afternoon, everybody. Bye.